Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences video podcast. I am Heather Hoops Matthews here in the studio today, joining remotely first with Lauren DeMoss, a Maynard Nexon healthcare lawyer. Lauren, great to see you.
Thanks so much, Heather. It's great to be here.
And we are excited today to have Andy Schwartzkopf joining us. He is the General Counsel and Chief Administration Officer of Signature Medical Group. This is a multi-specialty medical practice comprised of more than 75 multi-specialty private practice physicians, providing a variety of care in the St. Louis and Kansas City metropolitan areas. Andy, thank you for joining us today.
Heather, thank you so much for having me. Lauren, great to see you as always.
Yes, great to see you as well. Andy, can you tell us a little more about Signature Medical Group, just some more detail about the practice and the different types of specialties?
Sure, absolutely. So Signature started in 2001. So we're 20 plus years at this point in time. We started off as a orthopedic only physician practice. And as we grew over time in 2005, we became multi-specialty. And so we added OBGYN, and then I joined in 2007. And at that point, we just had ortho and OB. We started to branch out into other small multi-specialty groups. Since we're independent, we really catered to groups that didn't want to be owned by the hospital. So we grew into rheumatology, general surgery, pediatrics, family medicine, and a couple other small specialties. So we happy to serve the niche in Kansas City and St. Louis as an independent physician practice.
And your practice, your group has really led the way on innovation in a number of ways. And Lauren was telling us about Medicare innovation over the past decade and how you've been involved, specifically with respect to participation in the bundled payment program. Can you share a little bit about what you've learned as your groups participated in this program?
Absolutely. So when the Affordable Care Act came out in 2010, they set up the Innovation Center with Medicare. And so that was really basically a task group that was trying to figure out how do we reduce the cost in healthcare. So actually our first interaction with CMMI, as it's known, Centers for Medicare and Medicaid Innovation, was actually an OB. So they had a 3-year grant program that we applied for. We were the only independent physician practice in the country to receive it. And what they were looking for is how do you reduce the preterm delivery rates in the Medicaid population? And so we took a look at that, talked to our OBs. We had OBs in urban, suburban, and rural markets. And we looked really for common threads as, why are these ladies delivering so early? And, many times they were delivering 32 weeks, 33 weeks, and having tough times with the baby. And so really what we found was that most of them were getting their clinical care. They were coming to their appointments, they were taking their medications, they were eating well. It was the outside stressors that were really causing these early term deliveries. And so what we ended up doing, and this is really kind of a precursor to how we set up our BPCI program, is we had social workers that we embedded into the OB practices. So there was a natural handoff when an OB identified a Medicaid mom that had issues that couldn't be addressed clinically. But the social worker was really adept at looking at community resources to help that mom out. And once we integrated those services, we improved preterm delivery rates by 35%.
Wow, that's impressive. 35% is significant.
It was really material, and we really had some challenging areas. Our rural population had high drug usage. As many as 30% of the ladies coming to see us had some sort of substance abuse, either with the mom themselves or within the family unit. And so just getting those interventions in place really made a huge difference in those delivery rates and reducing the stress on the moms. So that really led us into BPCI. And so we really took that embedded case management model and we translated it to the orthopedic space. So I don't know how much your audience knows about BPCI. I can kind of go a little bit of a background as to what the program is, what CMMI was looking to do with it, if you think that would be helpful.
Please, that would be helpful. Thank you.
So bundle payments for care improvement. So really, bundle payment really is taking an episode of care. So basically that's can be a surgical, it could be a medical. So we look at orthopedics and cardiac are the ones that we've handled in the past. So this would have been an acute care stay. So an anchor event, you had a surgery or a procedure done at the hospital. And then you looked at that total cost of care, including the 90 days post-stay. And what Medicare did is they came up with a target price, and participants would basically try and beat the target from a cost standpoint, but you had to make sure that you kept your quality metrics the same or better. And so it was a risk program. So participants that came in, they took risk, and in exchange for the risk, if they generated savings, Medicare would share those savings with the providing group.
That kind of sounds like how private business works at times. So that
it was really a good way to align incentives of providers that typically don't interact well with each other. So as an independent physician group, we really knew that the surgeon, at least in the orthopedic space, really controlled the bundle, really controlled the plan of care. And this is an area that most physicians, except ones that did a lot of managed Medicare work, really didn't have the data on, weren't really looking at, what was going on with the patient, kind of outside their scope of services. And so once we started to kind of unpack all the data in orthopedics, so the two big volume drivers in orthopedics are total hip replacement and total joint replacement, total knee replacement, hip and knee. And so you've got a fixed cost for each of those cases, so it's the hospital stay, usually it's a 3-day stay, and then you have the implant. So you've got about 40% of the cost that's fixed. You're not going to change that really any way. And so the remaining 60% of that 90-day cost is the post-acute care. So that's your inpatient rehab, that's your skilled nursing, home health, PT. Those are the big drivers, and those are also the variables in those cost equations. And so when we took a look at the data, we found a wide variety based upon market. So we had 60 groups, I think in 27 states that we convened for. So let me back up a step. So in BPCI, you had episode initiators. So those were the participating providers, which our group, St. Louis and Kansas City, separate tax IDs, they participated separately. They were participants, and then Signature, we acted as a convener, which basically meant that we worked directly with Medicare to help these other groups participate in the program. And we were at full risk with Medicare, and then we would offload a portion of that risk based upon the tolerance of each of the participating groups. And so what we ended up finding is across the country, there's huge variation in use in this post-acute care utilization. And the doctors were really kind of amazed that, I didn't know that 8% of my patients went to inpatient rehab. And because inpatient rehab is that's a high level acute setting that most patients don't need. And then, so you started to really take a look, and we'll get to kind of some of this data-driven stuff when we talk about AI a little later. But we really started to take a look at hundreds of thousands of patients, figure out, what patients needed to go to what level of care at what point in time. And, once the surgeon became aware that, hey, we've got a lot of patients going to inpatient rehab, then you figure out that the hospital they're doing cases at happens to own an inpatient rehab, and the discharge planner at the hospital is really the one that's then shifting the patient to the next facility, that we could intervene and come up with a better care plan, better for the patient, better for the payer, in this case, Medicare, and make sure that the patient's going to the appropriate level of care for the right amount of time. And so one of the interesting things that we found across the country, this was universal across all 27 states, was skilled nursing. So for the patients that went to skill, their average length of stay was 20.5 days. And we said, well, that's super interesting because Medicare pays 21 days after an acute care stay. And so all of these skilled facilities were maximizing the number of days that the patient was staying with them, when there really wasn't a lot of times a clinical rationale for it. And so once we've kind of put our protocols in place, took a look, and what we really tried to do is make everything data driven. We also tried to make sure with our nurse navigator program, which was kind of like the social worker that we had for OB for Strong Start. We used nurses in this case, and most of them, had come from the managed care space. So they were case managers. They really knew how to navigate, multi provider stays, how to really transition patients from one care setting to the next. So they really were very good in implementing these care plans that we made sure that the patient stayed on track. And, in a lot of cases, we were able to drive savings through the system, and the patient got a better experience. Our OB patients, the Medicaid moms, and our BPCI patients, all really, the feedback was they felt like this was a concierge type care because it was high touch. The patient always knew where they were supposed to be going, how long they were going to be there. And for many of the patients that didn't need to go to a care setting after discharge from the hospital, they went home, and we were able to arrange for home health to come into the house, PT to come into the house. So we really had all these interventions in place that were able to drive cost out of the system and improve the care and treatment of the patient.
I mean, Andy, given Signature's kind of extensive participation in the program, and you mentioned kind of all the different data that you were able to learn and understand kind of the patient episode of care, what do you see as kind of the future for innovation or payment models? And as a part of that, I'm curious to maybe how ASCs or ambulatory surgery centers play into this, and what you all kind of see as the future there.
So as you guys know, hips and knees have both come off what they call the inpatient only Medicare list. And so maybe 2019 is when hips came off. And so what that basically means is that if you're going to do a Medicare hip or a knee, they had to be done in a hospital setting. They couldn't be done outpatient. You could do commercial cases outpatient. That's been the way for years. But Medicare, this was a big change for them. And they actually implemented that change into BPCI. So right now, BPCI is in a 2.0 version. It's bundle payments for care improvement advanced. They recently announced an extension. So this program is going to be live through 2025. We'll continue to participate through that time period. So they've added these clinical episodes for outpatient procedures for hips and knees, and I think even shoulders. I maybe add in next year. So Medicare realizes that there's a site of service change that's really kind of happening across the country. These ASCs are well equipped to do. We've got one in our practice, which they call it a 23-hour stay facility. So the patient can stay, in one of those beds for up to 23 hours after the case is completed. So it's like a mini hospital, but not quite. And so you can do most healthy patients, hips and knees, safely and successfully outpatient now. So Medicare is sort of addressing that transition. COVID really drove the transition for the laggards because there was no bed space. A lot of them are elective. So, without the beds available, either the case doesn't get done or the surgery is done outpatient. And that really drove a lot of the movement to outpatient. So I think Medicare is playing along with that. But to your other question is, what's the future of, these sorts of programs? It's one that Medicare really struggles with. We've been super fortunate. CMMI is a really small group. They do have a lot of turnover, but there's only about 10 or 12 folks at CMMI that run these bundle programs. And so we've gotten to know those folks really well over the past, 10 years or so. And we've participated in roundtables to talk about, what's next, how do ACOs, interact with BPCI, how do we make kind of a one size fits all model? And I think everyone's kind of come to the conclusion that there isn't a really good one size fits all model available. And so even in BPCI, it's been a mixed bag of success. Obviously we talk a lot about ortho because that's what we do. BPCI has cardiac, it's got GI, it's got medical DRGs, so urinary tract infections, COPD, sepsis, those sorts of things are tough to manage. And so they've had a variety of successes, but for the most part, it hasn't been I think the level of success that they were really looking for to really drive that cost curve down. And so I think they're struggling with what's next, which is I think one of the reasons why that they've extended BPCI for another couple of years, to give them another few years to kind of think, how do you address some of these cost issues? And you hear kind of, people talk, and you've got, different camps, which is move everything to Medicare Advantage. So everything is under some sort of capitated model. You've shifted the risk to, some sort of commercial entity, and Medicare just deals with a very small subset of Medicare eligible patients. That's a tough one. So I don't know. I think that's going to be a tough question for the next 10 or 15 years, for Medicare to try and figure out, how do you take on more and more lives? I think the stat is 10,000 people a day roll onto Medicare. And so as the population continues to age and continues to live a lot longer than they used to, it's a big cost conundrum for them.
Another topic, if we can just change for a second, is private equity. Private equity has been a big player when it comes to consolidation and private physician practices. Can you give us maybe your vision for the future? Do you foresee a slowdown in any of that, or do you see that barreling on?
Yeah, so I would say up until about a year ago, I would get 3 or 4 emails and phone calls a week from private equity. And healthcare was a big space for them the last 5 years, a lot of growth opportunities. As you mentioned, a lot of opportunities for consolidation, driving some efficiencies. It's really slowed down, at least from my experience here in the last 12 months, with the rise in interest rates. So their cost of capital is really shot up. And, that return on investment gets a little tougher, with interest rates above 5. And I think that they've kind of realized that it's almost like the hospitals, so the hospitals go through waves where they buy a bunch of doctors and they get rid of a bunch of doctors, and they buy a bunch of doctors and get rid of them. And so I think the PE folks have bought a bunch of doctors, and then they figured out that when you've taken away the incentives, right, for them to be highly productive, that they no longer are highly productive. And, so I think that's tough. Most of the deals that we saw were, especially for physician practices, were what we would call a comp scrape type model, which is PE would pay them, some sort of multiple upfront, but in exchange for that, the doctor would give up 15% of his income over the next 5 years. So you kind of front load it, and then you take it back on the back end. And it's really tough. Our group, like I said, looked at a number of different models, and there were different flavors of PE over time. And then you've got some of the bigger players. Obviously, Optum has bought up a ton of doctors over the last 5 years or so. So I think right now it's probably waning, but I would think that as interest rates, the cost of capital lowers for them, we'll see a resurgence in PE.
Now, Andy, we'll wrap up with kind of one last question, and I feel like, Heather, this is becoming a standard for our podcast guests. But yes. A lot of our recent guests have touched on artificial intelligence and how it's shaping healthcare in a number of different ways. One example is using AI to predict surgical outcomes, or how a patient's postoperative care can be adjusted or specifically planned for them based on how AI predicts that outcome. And I feel like, Andy, we've asked you to look into your crystal ball several times today. So one last time, do you think, what's your thoughts on AI? And you mentioned the data, that you all gained from participation in the bundled payment program. Is it something the practice is talking about, looking at? What do you kind of foresee in terms of using AI effectively going forward?
So I think for the most part, we've got one doctor who is a breast surgeon, and I know her practice is using a little more AI to take a look at imaging and those sorts of things. Ortho, we're not quite there yet. But as I mentioned, so we built really kind of from the ground up a database that we use as a care transition tool for all of our groups. So that, nurse case manager, she'll enter data into that database to make sure that the patient's on their care plan. And so we've got hundreds of thousands of records. And so early in the program, we were able to get a bunch of Medicare data as well, historical data. And so we really kind of mined all that to come up with what we really kind of call like a risk score system. And that's kind of what AI is doing now, but they're doing it with tens of millions of patients, and they're doing it in lightning speed. We would really kind of hand mine the data, take a look at, okay, well, this patient's got 2 different comorbidities, they've got managed diabetes, and they've got kind of unmanaged, say, COPD. That's going to be a patient that's higher on the risk factor. So that patient's going to take a little longer to be optimized prior to surgery, and they're going to have a higher level of post-acute care. So that's probably a patient that's going to spend a few days in inpatient rehab. And so, I think we got pretty good at stratifying the different levels of risk and coming up with a really pretty good risk score that was based upon the data. So I think AI is all that's going to do is drive that kind of through the roof. It's going to be a lot more predictive and accurate than we could ever come up with, just given the nature of the artificial intelligence. And they'll do it in real time. But absolutely, it's going to be part of the future of healthcare, and hopefully to be something that drives some costs out of the system. I think you see that innovation curve at all kinds of different things, iPhones, you had the early adopters, right? And then you had like the early majority, and then everyone's got an iPhone. And then finally you got the laggards on the back end. So I think it'll be very similar with healthcare. It's how much does a physician trust the data? And how effective is it in really driving some of these care decisions, and how quickly can it be done? So yeah, I think it's here to stay, no doubt.
Well, it'll be interesting to watch, if nothing else. All that AI will transform, whether, you're for it or against it. It'll definitely be interesting. Andy Schwartzkopf, General Counsel and Chief Administration Officer of Signature Medical Group, serving the Kansas City and St. Louis metropolitan areas. Thank you so much for joining us today. On behalf of Lauren and the team, it's been good to have you and learn more about your group.
I appreciate the opportunity to chat with you guys. Thanks so much.
And for those of you who joined us today, I hope you enjoyed this conversation with learning more about Signature Medical Group. And we look forward to seeing you next time, right here on Taking the Pulse, a healthcare and life sciences video podcast.